like to welcome you to the campus of Lubbock Christian, particularly in the Department of Nursing. We're so glad that you're here today. We have a wonderful speaker. In a moment, one of our MSN graduates, Dalton Keel, will come and introduce our speakers. I would like to just do the housekeeping things. Welcome you, first of all. If you've not been here before, our restrooms are just out this door to your right and right around the corner. If you need proof of attendance for being here today, we have certificates of attendance. It is not contact hours, but it does prove that you were in attendance. And we're so thankful that you're here and welcome you back to the Department of Nursing. If we can do anything to help you, please let us know. Mr. Dalton?
Hello everyone, I want to welcome you to this Brown Bag Research episode, and I'm happy to be an MSN graduate, BSN graduate of LCU, and as a FNP student, a family nurse practitioner student, and a doctor of nursing practice student as well, I'm proud to be asked to do this. I'd like to first introduce our primary speaker, Dr. Daniel Hatch. Dr. Hatch received his Doctor of Nursing Practice from Texas Christian University, and his current rank at LCU is visiting professor. Dr. Hatch will serve as the LCU's Family Nurse Practitioner Program Coordinator, teaching and overseeing all aspects of the FNP program as it gets underway here at LCU. So Dr. Hatch has served as a preceptor to FNP students and still maintains practice one day a week as a family nurse practitioner, and he obtained his BSN and MSN from Texas Tech Health Science Center, and he is nationally certified as a family nurse practitioner, and also with the National Organization of Nurse Practitioner Faculty, correct? Okay. Secondly, I would like to introduce our invited responder, Dr. Emily Merrill from Texas Tech University. Dr. Merrill received her Bachelor's of Science in Nursing from the University of Oklahoma. Texas Women's University, she attended for her Master's in Science in Nursing. Texas Tech University, she received her Postmaster's Family Nurse Practitioner, and she received her doctorate from Texas Women's University in Denton, Texas. Currently, Dr. Merrill is the chair, chairman of she is the endowed chair of the Advanced Practice Nurse Studies and the department chair for APRN programs at Texas Tech University Health Science Center School of Nursing. This program is a graduate track for pediatric, adult, and gerontology, acute care, and nurse midwifery. Is this correct? And she is also a certified nurse educator from the National League of Nursing. She holds a family nurse practitioner certification from the American Nursing Credential Center. And she's recognized by the Board of Nursing as a family nurse practitioner. Currently, she is a family nurse practitioner with the Texas Tech Physicians Organization, formerly the University Family Physicians Network, in the Department of Family and Community Medicine at Texas Tech University Health Science Center. Now, if you'll join me in welcoming Dr. Hatch.
Wow, Dr. Merrill, you need to cut back on your activities. I'm exhausted after going through all that. Well, thank you for coming tonight, or today. I appreciate it. And thank you, Dr. Long, for having me and asking me to speak today. Essentially, I'm going to be speaking on the capstone project that I defended for my doctoral degree at Texas Christian University. What I presented there is equivalent to a porterhouse steak with baked potato with all the fixings on the side and dessert. You're going to be getting a couple of tater tots with a filet mignon, basically. So I really tried to make it smaller and condense it down just to give you an idea of the presentation. So just to get started, I wanted to talk about the differences or how PhDs and DNPs can work together. PhDs are invaluable in nursing and developing and carrying out solid research regarding clinical problems. New discoveries are being made every day in research, and the problem is that we started to notice we were generating all this wonderful research, but it was taking too long to trickle down to the bedside, and impact patient care. And so the DNP was created to take that wonderful research and translate it, determine the clinical significance of it, and then apply it if desired to the patient care setting. And you'll hear this many times, but it essentially is taking it from the bench to the bedside and then back again. The idea really with both of these terminal degrees in nursing is to work together to improve patient care, reduce waste, reduce healthcare costs, and provide leadership through improving healthcare in general. One key element to that is the use of evidence-based care. So evidence-based practice is making clinical decisions that are supported by sound research. It's not acceptable to practice based on what you were told, what you think you should do, what you've always done in the past. It really is important now to adopt practices based on research that supports your decisions. People are injured every day by poor medical decisions and errors, and it's our responsibility as professional nurses to reduce those mistakes. As a parent now, healthcare resources are a finite resource that we have, and costly unnecessary tests, treatments are driving up the costs of healthcare. It's important that we use ways to efficiently improve healthcare for the general population. So nurses in general are poised as a workforce to really impact the healthcare system of the future by implementing sound evidence-based practice, but they have to possess the right skill set and be educated effectively on research. This is a general pyramid based on the levels of evidence, the top or the peak being the highest level of evidence, and then trickling down a reduction of the levels of evidence below that. Random controlled trials are essentially the gold standard for quantitative research, but systematic reviews look at all the evidence, everything available in the literature, and then makes a judgment based on the effectiveness of this. And it's done through a complex series of steps. So where does a clinician go for relevant research information, and how do they find the time to keep up with that information? Where do they go for guidance? These are a couple of sites for information that may be helpful to you, and they've been helpful to many practitioners. Up to Date is available for yearly prescription or subscription rate for the individual, $495 per year. And what it is a physician peer-reviewed research publication of medical journals and clinical topics, and they grade those recommendations, and they provide recommendations for the treatment and preventative services. Clinical Evidence is a international peer-reviewed journal as well, sponsored by a British medical journal. It's a little less expensive, $135 per year, and it provides access to over 3,000 systematic reviews based on a range of clinical topics. It also grades the quality and the strength of the evidence that they present. Cochrane Reviews is an online resource for systematic reviews. It's usually provided through an institution, and there is a charge to the institution for the use of that, but it's an excellent source for systematic reviews. AHRQ is a free online resource to you for evidence-based treatment guidelines, and it's provided by the Agency for Healthcare Research and Quality. Then when you look at individual peer-reviewed articles that you want to review yourself, Medline is provided by the U.S. National Library of Medicine, and it provides access to biomedical journals from all around the world. And CINAHL is a database, usually through an institution as well, that provides comprehensive research from nursing and allied health journals. Okay, so that leads into my presentation for diabetes, which is a very big clinical problem that I see. It affects over 25 million Americans. 95% of Americans with diabetes have type 2 diabetes. It's progressive in the fact that it leads to declining beta cell function and leading to the use of insulin therapy. And then it's also destructive, causing retinopathy, neuropathy, nephropathy, and vascular disease. The only way we have to really control this disease is glycemic control through oral agents, injectable GLP-1 agonists, or insulin therapy. So the problem that I identified as a clinician was, what guideline do you utilize to guide the initiation of insulin on the type 2 diabetic patient? There are plenty of very good guidelines that have done systematic reviews or meta-analysis of the data, but they've all come to different conclusions. And so I took it upon myself for this project to look at the evidence and decide for myself a protocol for treatment. So I reviewed the current relevant literature, evaluated and determined the significance of that literature guiding the treatment of type 2 diabetes, developed an evidence-based protocol based on the synthesis of that literature. And I attempted to use only the highest level studies for the development of the protocol, which include meta-analysis and guidelines, random controlled trials with narrow confidence intervals, and smaller random controlled trials or experimental studies with a little bit wider confidence intervals. So the first question I wanted to ask is, what is the link between glycemic control and diabetic complications? Is that an independent variable? The DCCT was a trial, random controlled trial of over 1,400 subjects studied over 6.5 years. And they had an intensive arm where they treated patients below an A1C goal of 6% versus a standard arm that was less intense. And what they found was intensive therapy significantly reduced nephropathy, retinopathy, and neuropathy, but unfortunately also had a 3-fold increase in hypoglycemia. UKPDS was a 10-year study following over 5,000 patients, and it showed sustained reduction in microvascular complications, and the incidence of AMI was reduced with the early use of oral agents and or insulin therapy versus diet and lifestyle modifications only. What's interesting is that they found the best reductions were in the early insulin users. Advance was a random control trial of over 11,000 patients comparing intensive A1C reduction versus standard A1C reduction. The intensive therapy was around average patient received a reduction about 6.5% on their A1C. The standard arm was about 7.3%, and with just that minor reduction or change between the two arms, in the intensive arm they noticed over a 10% reduction of major complications. The ACCORD trial, was a trial where they compared intensive therapy, dropping patients below a 6% A1C, and then they had a standard arm that was less intensive. It was supposed to be a 5-year study. They had to halt this study after 3.5 years due to the intensive arm showing an increase in all-cause mortality. And then the VDAT trial was a very large random control trial by the Veteran Affairs Department. It showed when they compared patients treated to 6.5% versus treated to 7.5%, no significant difference in complication reduction. But this study in itself has to be closely looked at, and the fact that it was a mainly male population that was used during the study, and over 40% had cardiovascular, pre-existing cardiovascular problems, and 62% have pre-existing microvascular complications when they entered the study. So the next study, or the next question I had was, what should the A1C goal be for type 2 diabetes? Well, the AACE guideline suggests, and this has been updated to 2013, less than 6.5% in standard populations, greater than 6.5% in special populations. Now, special populations includes patients with a history of severe hypoglycemia, extensive vascular disease, or limited life expectancy. AAFP guidelines, they suggest less than 7% for their standard populations, or 7 to 8% in special populations. The combined ADA, EASD guidelines and IDF guidelines both suggest less than 7% A1C reduction with less stringent goals in certain patients. And then DCCT, just a reminder there, they did push patients below 6% and saw a 3-fold increase in hypoglycemia And interestingly, 2 of the patients in that intensive arm died from automobile accidents secondary to hypoglycemia. The Accord trial, again, a reminder, they had to terminate the intensive arm after they pushed patients below 6% because of an increased risk for all-cause mortality. And then UKPDS did show that if you will reduce patients early in the course of therapy with insulin, that you can have a substantial decrease in complications. And they treat patients at an average of 7.4% in the intensive arm. Okay, so this is a graph that was taken from the outcomes of DCCT. And I'm a very visual learner myself, and so it's very easy to look at this and distinguish that there is a direct correlation between A1C reduction and the relative risk of complications. As you can see, around 6% they have essentially the same risk as the general population, and then it slowly increases. In the higher the A1C, the more substantial the risk increase goes up. So what is the proper time to initiate insulin therapy in type 2 diabetes? Well, the ADA-EASD guidelines suggest after max dose of metformin and sulfonylureas, go ahead and start insulin therapy. They also state that they recommend earlier use of insulin therapy in the course of treatment. AACE guideline recommends adding insulin after failure on 3 different agents with the option for the clinician to start insulin sooner if desired, even as a second-tier drug. AFP guidelines suggest, and it's very vague in general, I'm assuming they're trying to leave that up to the clinician's decision, but after failure on diet, exercise, and optimal doses of oral agents, then you should start insulin. IDF suggests initiate insulin if their A1C is not met on max oral agents. And then again, UKPDS showed that if you'll start insulin therapy early in the course of the disease, they had the best outcomes. So what insulin should we use? Well, we're fixing to talk about that, but I wanted to kind of give you some definitions real quick about basal insulin, because you'll hear about this more. Basal insulin addresses background hyperglycemia, and it's needed to suppress hepatic glucose production overnight in the fasting state and between meals. If you think about it, the average individual spends most of their time in the fasting state, and so if you're going to start something to address glucose control, that's the best place to start. Types of basal insulin include NPH, which is an intermediate acting human insulin, and then Levemir and Lantus were genetically modified human insulins that were made to be longer acting and have a better absorption rate. This is a graph showing the release in the human body of these different forms of insulin. Specifically, I'd like you to look at the purple line, that's NPH, and it seems to peak or spike about 6 hours after dosing. The problem with that peak or spike is it led to an increased risk of hypoglycemia, especially at nighttime. Most patients dose these basal insulins in the evenings to cover the longest period of fasting, and so there were more complications associated with NPH insulin. Detamir or Lantus, either one of those, have more of a controlled, sustained release. And if you'll see that Lantus or glargine, it is the actual only true 24-hour insulin that really doesn't even have a peak effect. It has a more of a sustained, smooth effect. Okay, so as far as type of insulin, all these guidelines suggest some form of basal insulin. Now, some are more specific than others. The AACE specifies using a long-acting basal analog. AAFP just generally recommends a basal insulin of some kind. The IDF allows the provider to decide between basal and premix, which is NPH with a regular insulin added. And then ADA-ESD guidelines suggest either basal insulin or a premix with an emphasis on using a basal insulin. So the 4T trial was a random control trial looking at patients treated with insulin premix, NPH alone, or basal analog insulins. They all in the study had substantial or good A1C reductions to goal, but the basal analog insulin had the least hypoglycemia and the least weight gain associated with it. LandMet was a study that compared patients already on metformin, and they added either NPH or Lantus. Both were equal in effectiveness, but Lantus had less hypoglycemic events. Treat to Target had patients that were already on 2 oral agents, and they were either put on NPH or Levemir. The NPH actually had slightly better A1C reductions in this study, but they had substantially more hypoglycemia and weight gain. Predictive took patients that were already on NPH and Lantus and removed them from those insulins and placed them strictly on Levemir. They were able to show outcomes that showed improved A1C reduction and less side effects. This study needs to be looked at closer, though, because it's a non-randomized controlled trial, and also the individual dosing was left up to the individual provider of each patient. There was no standardization. A meta-analysis of 16 random control trials comparing basal, biphasic, prandial, and basal bolus therapy showed basal analogs offered better glycemic control and less hypoglycemia. So how do we initiate the insulin? The AT Lantus trial compared clinician versus patient-driven algorithm, starting at 10 units and allowing adjustments of 2 units every 3 days of Lantus. They showed equal effectiveness between the clinician and patient-driven algorithm, but the patient-driven arm was tolerated better. Initiate looked at group versus individual education of patients. Also using the same schedule with Lantus, initiating 10 units and adjusting by 2 units every 3 days. What they found is equal effectiveness, and that they proved, or the study proved, that you can educate patients in a group setting, and you did not have to do individual one-on-one education with this kind of algorithm and have still confidence with the patient that they'll have good outcomes. Titrate took insulin-naive patients that were only on oral agents and did a little more aggressive titration schedule with Levemir, starting at 10 units and adjusting by 3 unit increments every 3 days. And they showed adequate output and good tolerability. Predictive 303 compared clinician versus patient-driven algorithms using that same aggressive algorithm of 10 units, adjusting by 3 units every 3 days. And they showed good outcomes, but moderate hypoglycemia with this. So based on all those studies, after you had to strain through all that, these are the components, or the development of the protocol. I felt like we did determine that glycemic control is an independent variable in reducing microvascular risk. A1C goal should be, for the average patient, 6.5 to 7%, in special populations, 7.5 to 8%. Initiate insulin early in the course of the illness by maximizing only the use of 2 oral agents before you start insulin. Use of a basal analog insulin as your insulin of choice. And then using a clinician's set initial dose with patient self-adjustments, starting at 10 units and adjusting by 2 units every 3 days for the average patient, or 5 units and adjust by 2 unit increments every 3 days for special populations. And let me hand out the protocol real quick to everyone. I hope I have enough here.
Can you help me with that, Dan?
Sure.
Continue to talk.
Sure. And this is actually a flow sheet that shows the full protocol in a little more depth than that the clinician can follow. Okay, so the problem is there's barriers to insulin, and that was the problem that I realized that most clinicians run into. Patients have fear of needles or self-administration, fear of pain, fear of making a dosing error with their insulin, fear of hypoglycemic risk, a misperception that insulin's an end-stage drug, inability to forward medications, and then many of them have variable meal times or non-regimented lifestyles. The thing that I'd like to draw your attention to that is most of those things can easily be countered by a good relationship with your patient, a trusting relationship, and good education. So hopefully one day we won't have to use needles we'll find some other route. But for right now, unfortunately, we're stuck with injecting insulin. The implications of this protocol, I felt like barriers really needed to be addressed adequately in order to implement a protocol and adhere to the protocol by the clinician and the patient. Clinical practice protocols can really improve the consistency of care, eliminate waste, reduce healthcare costs, and improve patient outcomes. If you have some sort of standardized or protocol-driven algorithm you can go by, in general, your patients will have more consistent care. And then I want you to consider that your actions by using evidence-based care is like a ripple in the water. It will start to affect other people outside of you. Your patients will start expecting that level of care. Other clinicians will start emulating what you're doing, and eventually that ripple will turn into a wave that will wash over healthcare and really improve the quality of healthcare in general. So some future directions that we can go with after this protocol was developed. I realize that education of the patient early in the course of treatment is important if we're going to utilize protocols. Research the barriers to insulin and ways that we can counter those barriers, and then develop an alternative action plan of treatment. Expand the use of treatment protocols in the clinical practice setting. That's it. Thank you. I appreciate it. Dr. Merrill, would you like to come up? You're welcome. And one other thing, I do have the full references up here at the front. We want to put those on a
Thank you very much for this invitation today to respond to Dr. Hatch's presentation. First of all, thank you, Dr. Hatch, for your contribution to nursing and to the health of our nation. This is really an important, fascinating, and profoundly well-done study. I could not imagine the number of hours that you have spent synthesizing the literature.
A long time.
A long time.
A 5 months will
I commend you for your scholarly approach to an aspect of care that is really important when you think about the number of diabetics, the number of patients and families who are affected by diabetes. This is going to be an important finding, an important protocol. It's going to reduce cost, I believe, as well as human suffering, and improving patient care, and it's going to affect how we as advanced practice nurses practice, which is very significant. As we all know, evidence-based practice has gained great momentum, and in practice as well as schools of nursing. And I'd like to commend Lubbock Christian University and Dr. Long and the faculty here for highlighting this, for having these kinds of meetings and organizations where you can discuss these kinds of things and where this kind of synthesis is noted. So thank you, Dr. Long, and for LCU faculty. I think Dr. Hatch has met the mark in synthesizing evidence to improve patient care, and I think that you're going to see his study, his protocols in the literature, and I know that's going to be a happy day for him when it's in publication. One of the greatest things you can do after you do a study is to disseminate it to people that it's going to matter to, and that means the public, and it means providers and people that are involved in healthcare. So this is a big first step in disseminating the information. So Dr. Hatch, congratulations. Well done, and I think you are privileged to hear this. This is probably the first time you've presented this in Lubbock, and I think you'll be presenting this in the future. Thank you very much.
Thank you.
I'd like to see if anybody had any questions that I could answer about the protocol or any of the information that I provided. Does anybody have any specific questions? Yes, ma'am. No, it's Dan.
I'm just wondering, it's probably just created a lot more questions, your presentation. And I'm wondering if we initiate the exercise and diet earlier, instead of starting the insulin? I don't know, do you think that they would need the insulin or have the diabetes if we had the exercise and diet?
I think preventative care is the key for sure. Avoiding obesity, having them live a good, solid lifestyle. But I think that, like I kind of quoted about the UKPDS trial, they did kind of compare patients that were early identified in the disease process, and they just put them on a very strict diet, good exercise plan, versus treating with meds. They did not see the same outcomes. So I think that if they already have gone over that threshold into active disease, that they probably need active medications as well. But prevention is the key. I think if you can get to them before they cross that threshold, that would be awesome.
I guess we have to pick who is going to be the one we have to focus on before.
Yeah, identifying risk factors, I think, for sure, and then addressing those during visits in the clinic. Yes, ma'am?
And the fact too that most people with type 2, when you put them on a healthier, dietary regimen, let's say lower carbs or whatever, or better carbs, they can maintain that for a short time, but after about 6 months, the ability to keep that up really does wane. It really does not. So really and truly, probably starting them off and getting that glucose under control, really gives that patient that, oh, this is working. And so, because we know that the failure from trying to control the diet does not work.
There was an article that I read, and it didn't really pertain to my study, so I didn't keep it, but it showed just patients starting on metformin made a huge, substantial reduction in their outcomes versus just doing diet. And so I think getting them started on something that decreases that insulin sensitization problem, and also still giving them the education and the follow-up, that's the other thing. I think if you continue to talk with them, visit with them, and follow up on the disease, how active that is and how severe it's becoming, and address it early on and not wait a couple of years between the visits, that really helps too. Unfortunately, people kind of fall through the cracks sometimes, and like you said, they get complacent, and maybe they thought, well, I did this for a while, I'm fine now. They don't realize it's a life-altering disease. So. Yes, ma'am.
On your slide where you listed common fears and reasons people wouldn't use insulin, I saw you said that people assume insulin is a long-term, never coming off of type of drug. Did you come across any kind of literature that gave a certain instance to where people actually did come off of insulin? I was just curious about what those numbers might be.
Really more what I was trying to say was end stage, meaning people think I'm at the end of the rope and I have no other alternative and now I've got to go on insulin. But to answer your question, that's a good question. I don't remember coming across any specific articles about people actually weaning off, but I will tell you that most of your patients that come in and they're initially diagnosed with an A1C of 9% or greater should probably be put on insulin right then to drop their A1C to a substantial amount. Then they may actually enter what they call a honeymoon phase, where they don't need insulin for a while if you can get them rapidly controlled. And so there is a lot of literature supporting early initiation of people that are at high A1Cs when you first see them and first diagnose them. Yes, ma'am.
Just looking at the protocol that you've given to us, I'm curious, in your practice, when you institute the insulin, do you see results of that A1C coming down within the 3-month period and quite well under control, or is it still
It's variable.
floating?
Yeah, it's variable depending on the patient. Some have a greater insulin need. I think just getting their feet wet, showing them that you're not going to die if you start this insulin, and kind of allow them to call me and come back in for questions, those kind of things. I do see reductions that are impressive, and they actually feel better usually during that 3-month trial, but not everyone gets to go within that 3 months. It's an ongoing process for sure. Yes, ma'am.
And I just want to comment too, and it's only because this is what I've done for years,
Sure.
as a diabetes educator. And so physicians have threatened patients with the fact that if you don't comply, then you will be on insulin.
Yeah.
And so it's
That's the end-stage drug thing,
punishment.
yeah.
And so in their minds, that's why they think this is the last resort.
Yeah, we need to change that
Exactly.
mindset.
Change that mindset and explain that it is progressive disease. early on, and that more than likely they're going to need insulin at some point in their life.
Exactly. I think that's why, starting early and talking to them about this protocol and saying we want to actually initiate this as a therapeutic drug for you probably early in the course of your illness, and at some point you will need to use this medicine, and it's not something to punish you and kind of offset that. But you're right. I've heard that many times, and patients will say that to me as well, that other providers have told them that, or they're scared because they think it's a bad thing. So one thing that is helpful too is the delivery systems. In my practice, I like the pins, the OptiClicks and those kind of, different kind of pins that they can dial in. They can see the number. They know they're not going to draw up something wrong, and they feel like it empowers them a little more, and they're not as scared about hypoglycemia and doing something that will kill them. So I think that's a great step forward that they've done just in modifying the delivery system of those insulins. Unfortunately, they're expensive, but there are discount coupons and other things that are available to help those patients for sure. Anybody else?
Could you say a word about the trials that included patient-initiated?
Who's the rude person with their cell phone on? Sorry.
Actually testing the efficacy of allowing patients to initiate their dosing, and what that might mean for us in terms of a paradigm shift as we think about, we're the ones that educate the patient, but this is definitely a more partnered approach.
Right.
And I don't know, we certainly have not always taught that, and yet these trials that show that they were equally as efficacious when we allowed the patient to have control over it. What is your take home to all of us that are in practice about the role of the provider in empowering the patient to have control over their regime?
Well, the move is obviously that we want to have our healthcare be patient-centered and individualized for that patient. And so in order for that to happen, really they have to be an equal partner in decisions that are made in their own care. The idea really as a provider is trying to guide them and give them the best information so they can make a good educated decision for their own health. Some people have different decisions about what is their quality of life they want to have, what is important to them, what are they willing to do for that quality of life. So to answer your question, I really think that, and based on the literature, it seemed that patients were more empowered, they felt in control more, the outcomes were better because they actually could adjust their dose more rapidly and make their own changes and decisions than contacting the clinician. And I think that's really the wave of the future. We'll probably see medications being tailored specifically and preventative testing and other things tailored to specific needs of patients. And those conversations will come up. They're already coming up right now about PSA testing and other things like that when we're doing physical exams. That's an individual choice. There are specific guidelines and recommendations, but you just have to kind of present that to them and empower them to make those. Because essentially they're the ones that are going to have to live with the decision. And so they're the ones that need to be the one making that decision. Yes, ma'am.
In doctoral studies, people are always...
Are you trying to think of questions?
I'm always fascinated why and what leads somebody to decide what they're going to study. That's a fascinating thing because, as nurses, as healthcare providers, as somebody who already has a master's degree and you've been a nurse practitioner for now at least 11 years. And I don't know if you know this, but Dan was my student, and I was the person that came to visit him, watched him in clinical, watched him acquire these terrific skills that he has, and I'm extremely happy for him. But back to the question, what is it that makes us curious as scholars? There has to be a curiosity, because every day in your own practice you have things that you say, why is that?
Yeah.
Or what could we do about this? And that is really a scholar. You think about, what could we do? What is the question? What could I study? What could I explore? What could I do in this? And as a doctoral student, think of the thousands of things that he could have studied. Thousands in his practice. He had 11 years of experience as a nurse practitioner. In family, you see, from infants to people who are dying. What is it that led you to say, this is what I want to put my time and energy, what am I going to be known for? Because as long as you live, people will say, what was your capstone? What was your dissertation? You know, they want to know. So, Dan, what was it?
No, I felt like diabetes is such an upcoming and progressively severe problem in family practice that I'm seeing more and more of. There's not enough endocrinologists out there to manage these patients. We have to deal with it in the primary care setting on a regular basis. And so I wanted to have the information to really guide my practice. It was a question that would come up numerous times.
Yes. And you were frustrated by that.
Yes, very. And
Because there
even
was-
I would ask other experts, and
Yes.
I'd get different opinions every
Yes.
time. And so I really felt like it wasn't benefiting the patient by staying in the dark about that. So that's how I chose my topic, for sure.
Thank you.
Yes, ma'am. Anybody else? Thank you all very much. I really do appreciate your time.